Alright, this is going to be Neonatal Emergencies and Transport Part 3. And in this section of the slide set, we're going to talk about cyanotic defects. Cyanotic defects, characterized by poor pulmonary blood flow resulting from one or more of the following: difficulty in pumping blood out of the right side of the heart, greater pressure gradient from the right to the left side of the heart that shunts blood to the left side, returns unoxygenated blood to the left side. So what this is going to do is this is going to essentially remix deoxygenated blood on the side that's pumping it out to the tissues. Now this can become problematic if it compounds, if the child's under any distress at all. Blockage of the pulmonary blood flow or structural deformity. Complete transposition of the great vessels, characterized by abnormal positioning of the aorta and pulmonary arteries. Pulmonary artery leaves the left ventricle. The aorta leaves the right ventricle and creates parallel circulations. Associated with atrial septal defect, ventricular septal defect, and patent ductus arteriosus up to 80% of the time, and has to be for the patient to survive. Without these defects, no enterocardiac mixing of oxygenated and deoxygenated blood occurs, and the child dies due to closed parallel circuits. Degrees of cyanosis and acidosis depends on the number and the size of enterocardiac and extracardiac shunts. Complete transposition of the vessels continued here. Signs and symptoms of this: very easily difficulty breathing, tachypnea, and tachycardia, and obviously cyanosis. Management: give supportive care. Surgical repair via arterial stitch is the definitive treatment. Alright, so this is the aorta, and this is the pulmonary artery. So as we'll see here, the right side, instead of pumping blood into the pulmonary trunk, pumps blood to the external body, which is deoxygenated. The left side, on the return, pumps blood into the pulmonary trunk. Now, without any atrioseptal or ventricular septal defect, there would never be any oxygenated blood getting to the tissues. Tetralogy of Fallot. Condition characterized by 4 criteria: ventricular septal defect, pulmonary stenosis, rightward displacement of the aorta, and this overrides the ventricular septal defect, and right ventricular hypertrophy. Degree of cyanosis, secondary to mixing of the oxygenated and deoxygenated blood, determined by the degree of pulmonary stenosis. Greater the pulmonary stenosis, the greater the right side's interventricular pressure, the greater the right to left shunt, the more deoxygenated blood reaching the systemic circulation via the aorta. And it's got a nice picture, and we'll talk through it here in just a second. Signs and symptoms of Tetralogy of Fallot: tachypnea, tachycardia, fatigue at feedings. Management: give supportive care, ensure adequate oxygenation, and administer prostaglandin, which is essentially going to keep the patent, will keep a patent ductus arteriosus in place, which will allow for collateral circulation, depending on how severe the rest of the symptoms are. So there's a ventricular septal defect that essentially offsets the aortic semilunar valve towards the right. And what this causes is there to be deoxygenated blood shunting in with the oxygenated feed. Depending on how severe this hypertrophy is, or this pulmonary artery stenosis is, and how big this is, depends on how many symptoms your patient is actually having. Transport guidelines for congenital heart defects: ensure a patent airway, ensure adequate ventilation and oxygenation, treat any congestive heart failure that might arise, correct circulatory compromise, conduct fluid volume resuscitation, and administer vasopressors when needed, and keep the patient warm. General pathophysiology of other neonatal emergencies. Necrotizing enterocolitis. Most common serious abdominal emergency in neonates that requires emergency surgical intervention. Acute inflammation of the large intestines leads to necrosing of the intestinal mucosa. Risk factors include an insult to the intestinal mucosa and bacterial growth. Causative agent has not been identified. Risk of sepsis secondary to bowel perforation, and this would cause peritonitis in the neonate. Signs and symptoms: abdominal distension, decreased or absent bowel sounds, vomiting, bloody diarrhea, lethargy, poor feeding habits, depressed core body temperature. Management: give supportive care, keep the patient nothing by mouth, insert an NG tube and conduct gastric decompression, maintain acid base and electrolyte balance, maintain IV fluids, administer antibiotic therapy. Sepsis: life-threatening infection in the bloodstream resulting in systemic toxicity. Often subtle in neonates and may be difficult to distinguish from a non-infectious pathology. Maternal gastrointestinal or genital infections are the most common etiology on this. Primary site of infection may often be difficult to identify. Shock may develop, resulting in vasodilation secondary to the release of bacterial endotoxins. And what we're going to get from this is we're going to get a distributive shock. Signs and symptoms: respiratory distress, pulmonary hypertension, hypoxemia, severe hypoperfusion, and signs and symptoms of shock. And then if we allow this to go and continue without getting ahead of the pathology, or even if we don't, sometimes we can get disseminated intravascular coagulation caused by a stacking autoimmune response of the red blood cells, and essentially clogs up all filtering organs. At the same time, it decreases your clotting factor. So not only are you bleeding out, but your kidneys are failing, your liver is failing, you have PEs, strokes, heart attacks. The exotoxins, as a defensive mechanism from the bacteria, get released. The macrophage, or the white blood cells, releases their own chemical warfare, which are called cytokines. The two of these together causes the fenestrations on the capillary to seep or leak fluids into the interstitial area. This eventually will break down the vascular walls and create a leaky system. Management of sepsis: general supportive care, ensure cardiovascular support, administer antibiotic therapy. Now, the cardiovascular support may be in the form of fluid and or vasopressors, and multiple types depending on what the etiologic agent is and where it's actually attacking. If it's truly vascular, you should probably lean on something with an alpha response. General neonatal assessment findings and considerations. Skin color. Cyanosis is commonly found in neonates, insignificant when the neonate is crying. Jaundice is a result of high serum bilirubin levels, usually resolves without intervention. When needed, treat with a fluorescent light. Blood transfusions are going to be needed whenever the fluorescent light treatment fails. Vital signs. Neonatal vital signs are variable and they deviate from the norm. Access to reference material is going to be pretty much your saving grace in this, or advisable. Pediatric Braslow's tape or a pediatric pocket guide would be helpful. In addition to respiratory rate, blood pressure, heart rate, consider blood glucose pretty much a vital sign in the neonate. It should be 70 to 80 milligrams per deciliter. Consider non-hypoglycemic. General neonatal considerations. The airway should be secured and maintained as soon as possible. If RSI is the way that you need to facilitate that, then RSI is what you need to do. Accidental extubation is the most frequent problem whenever we look at respiratory complications. Be sure that sedation is on board. Neuromuscular blockades and their effective times have been kept up with. Once we get the child or the neonate intubated, C-collars are applied and there's some sort of lateral immobilization. So in case they move, it won't extubate them. The tubes are uncuffed. They seat on the first cricoid ring. Vascular access. Obtaining vascular access can be difficult as well, even for the experienced provider. Multiple access options should be available. If you have an IV and have someone skilled enough to actually facilitate one, then get an IV. If you have an IO and you can't get an IV, there should be multiple options here to obtain IV or vascular access. The umbilical route would be another option as well. The umbilical vein is what feeds from the placenta via the umbilical cord to the neonate's inferior vena cava. A cannulation device can be implanted into this, which will give central access. So it's like having a big gigantic central line. Once that's placed, some way or some form to secure the catheter should be implemented. Temperature regulation. Temperature regulation is critical. Should be considered constantly to ensure that the neonate's temperature is regulated during transport. Temperature regulation initially provided by preventing heat loss while promoting strategies for aggressive warming. Before the transport, we should use radiant warmers, insulated blankets, and heated blankets. During transport, we should really lean on our incubator or isolate and be sure that the temperature is adequate. Hypoglycemia should be managed aggressively. Use 10% dextrose and water. The infusion, normally we infuse dextrose 10% water at 80 cc's per kilogram per day. Dextrose 25% and dextrose 50% is contraindicated, and that's because it's going to cause an osmotic shunt. A very thick material, it'll pull tons of fluid to it. It can cause hypernatremia and cerebral edema. So please be sure that you're close to or delivering 10% dextrose and water. This ends part 3. If you have any questions, feel free to contact me. My name is Roy Smith, roy.smith@redlandscc.edu or smith@imsa.net. Thank you.